Hello,
Yep,
Dr.
see
Gwon,
you.
Hyeon-Cheol Gwon.
Hi.
Hey,
Hi.
how are you?
Nice to see you here. Good morning.
We can see you and you can hear you clearly. Can you
Yeah,
introduce your case and
Yeah.
your team?
Yeah. My name is Hyeon-Cheol Gwon from Samsung Medical Center, and right beside me is the Dr. Ziad Ali from Columbia University from New York. And he's the expert in the complex PCI and also the OCT. Yeah. And Dr. Yang from Samsung Medical Center. So we got some trouble before we preparing the case actually, so it'll be very exciting. So Dr. Yang, please introduce our case.
Okay.
Next slide.
I'd like to introduce today's case. And a 72-year-old female visit another hospital with exertional chest pain several years ago. And she received coronary angiogram. She had cerebral vessel disease and was transferred to our hospital for second opinion. Her echocardiogram showed normal systolic function without any regional wall motion abnormality. On her medical history, she had a history of hypertension and diabetes. Next. Her ECG findings show normal sinus rhythm without any STT change. Next. We have already treated right coronary artery region, and as you can see here, we can see the tight region with heavy calcification at the proximal to mid portion of right coronary artery. We have some big difficulty to pass the stent, and anyway, finally, a successful PCI was done. Next. As you can see here, aerial view, you can find the mild atherosclerotic plaque at the proximal to mid portion of LAD. Next. As you can see on the aerial view and aerial-caudal and epicaudal view, we can find the left main trifurcation region with heavy calcification. Next.
So we have the RC was treated with the rotablation and 2 stents, but even after rotablation, the previous operator have some difficulties crossing the expand the stent and cross the stent. Anyway, this is a heavily calcified lesion in RCA, and I expect the same very heavy calcification in the LAD and also the obtuse marginal, as you can see in the angiogram. So how to prepare calcified left main trifurcation, how to protect the side branches during stenting, and what's the best stent strategy, and what is the best imaging modalities. This is the issue today. So actually, Dr. Ali is expert in the OCT, and he recommended the OCT to evaluate the thickening or length and a lot of information. So can you explain a little bit about OCT role?
Of course. So thank you, Professor Gwon. Pleasure to be here in Seoul. So there was a number of questions despite this angiogram that we weren't really sure about. We know the patient has severe calcification, but it wasn't particularly clear whether the ostium of these lesions were severely calcified. We've published in 2017 some clear criteria about whether or not we should perform rotablation due to risk of underexpansion. And so we plan to perform OCT, which allows us to look at the thickness of calcification in addition to the arc as well as the length of calcification. So our plan was to do OCT of the first, the ramus or the obtuse marginal branch, and then do the LAD. And then as with real-life interventional cardiology, we ran into some difficulty. And so what I want to start with is show you our first OCT. Could you put that up, please?
Can we see the OCT image?
Could you put the OCT
Yeah,
up,
OCT?
please?
Yeah.
OCT image on the screen, please. Okay.
Thank you. Okay, great. So now you can see our
Don't
OCT,
slow-
and you're
don't
going to
slow-
see
don't
something rather interesting
좀
right from the beginning.
달라고.
So all we were
어떤
really
거니까 아니야.
interested in the OCT was
오른손은?
to look at the osteum of this vessel. So if you look at the osteum, this is the left main.
이거 아니고.
You can see
오른손은?
areas of
하나 더 줘요.
well-circumscribed plaques. Those are calcification. And then as we go into the ramus, we see severe osteocalcification, eccentric, sort of a calcified nodule.
좀 저거.
But you'll see very early on, there's actually a large flap in the proximal obtuse marginal. And as we travel down the artery, you'll notice something extremely interesting. And that is that the true lumen has now been compressed. Despite the fact that the wiring was very easy, this is one of the perils of severe calcification. And so we have a severe dissection which actually led to flow limitation with a very collapsed and small false lumen. So I'm going to let Professor Gwon talk to you about what we did next. There are very limited options when the true lumen is, of course, this small. Rewiring this with a flap of this size is difficult. So our strategy had to quite quickly adapt. So can we show some of the angiograms, please?
제일
The
처음으로
angios?
처음으로
Okay, so this is our first picture. Go,
Yeah,
keep going.
next.
Next. This is our LAD picture.
next. Okay, you can see more clearly the ostium of obtuse marginal is stenosed in the angiogram. So very good separation of the three vessels. Next. The wiring was not eventful, so I can say that so there is no resistance. Anyway, we try to do the OCT. Next. Next.
And so this is our first angiogram after the OCT, and you see now
Oh,
that there
sorry.
is, in fact,
Play,
no
play.
flow.
Play. Next. Okay, the flow was compromised.
So already because of this, we immediately went back to the OCT, which helped us make a diagnosis. And that was that there's a dissection in the proximal obtuse marginal leading to an intramural hematoma and complete collapse of the true lumen. So as a result, we decided to use a bailout strategy for the obtuse marginal. And so what we decided to use was a subintramural tracking and reentry, or STAR technique. So we move forward.
Next. Of course, we firstly dilate the obtuse marginal osteum because at the time we don't know the dissection was made on the false wires and the false lumen. Next. And balloon. Next. Then we found that the OCT, re-evaluate the OCT and found that the wires and the false lumen. You can see more clearly here. Next. So I tried to find the true lumen with another wire, but it was not successful. Then changed to a STAR. STAR. What is the abbreviation?
Subintimal tracking and reentry.
Reentry, right. So I used the fine cross catheter. Next. Next. And XTA wire, buckling and push, push, push. Next. Okay. Got through the true lumen of the obtuse marginal. Next. Next.
So I think we haven't taken a picture after that.
Find out. Next. No?
No.
Really?
So we can take a little picture for you and show that we've now reestablished
Actually,
flow.
I thought we had got a flow,
I
but
thought so. We do. We definitely have flow.
yeah, but it was compromised again.
I see. Okay.
Very
so
slow.
Maybe
very
we can
slow.
take a little puff here.
Slow. So there was a flow, but the meantime we waited for 5 minutes and the flow was compromised again. I inserted the microcatheter was in the lumen.
So
Okay, you
actually,
can see that? So
we might
I
actually
removed
take
the-
a tip injection here.
Oh, really?
Yeah.
Okay.
Because I think we might be in the true lumen distally.
Yeah.
So can we go ahead and take, show us the last angiogram,
좀
please?
줘봐.
Can you play the last angio?
다이
Yeah.
다이 좀
So you'll notice here that
2cc 시린지, 3cc 시린지.
we may be in the true lumen distally with our fine cross.
Yeah, I thought so. The wire is going.
So we may actually come back, put a
Yeah,
workhorse
yeah,
wire back in here.
And
And-
going that way?
Yeah, and if we are truly in the true lumen, we may protect that and use a crusade catheter and try to wire our separate branch and then slowly come back to the point at which we can find the end of the dissection, and we're going to have to perform some bailout stenting here.
So are you sure that distal wire is in the true lumen or?
We're not
Yeah.
really sure right now.
I cannot show you now, but it truly have flow after start technique. So
So
I
we may be
regret
able
I
to
c-
tell
can't.
by the behavior of this wire,
Mhm.
okay,
not too far back.
go, yeah. This
Okay,
way.
so that's good, right? So we're going into both branches.
But this is branch, and we are going that way.
So you think we're this far back? It's a different view.
Yeah. This is the better way to go.
Yep, yep, good.
Yeah, better to go.
So let's take another picture here,
Yeah.
and so we can have an idea. We're going to limit our total number of. We have
Okay. Very
we've
slow.
done a star.
Slowly, slowly, slowly.
Okay.
Okay. This is obtuse
Right.
module large branch. First wires. in
Right.
the-
So actually, we have probably re-entered into the true lumen
Yeah.
because we can see branches on both sides.
Why
Although-
don't you introduce the microcatheter and tube injection?
Yeah.
Well, I mean, that would be our next step. Of course, we have to give up the wire position, and we may actually be in the false lumen, but if we are, we're committed to a subintimal tract throughout. So we'll do that. We'll advance the microcatheter, and we'll do a tip injection and see if we're in the true. One thing that we've noticed is
I
we're not
think
seeing a
we
lot
are-
of branches down there.
Okay.
How about
This
check
one,
the
this-
IVUS in this situation?
IVUS.
That's an excellent
Yeah.
suggestion.
Okay.
So which wire makes that kind of a horrible dissection?
Run through?
Run through.
Yeah. There was no resistance, I'm sure, but yeah, wiring is very easy.
Can you open the IVUS, please?
I cannot
strange. So, of
cannot
course,
understand what's going
OCT,
on.
not a great,
Okay.
that's good, but could be flap.
Okay,
So
flap.
we'll put the wire back down this vessel, and we're going to IVUS this.
Looks like we are still
This is a
subintimal.
dissection. Yeah. Okay. So we may have to balloon this tract with a small balloon and let this to heal. Patient is stable hemodynamically. Heart rate is 52. Blood pressure is 118/63. And we may have to allow these dissections to heal. So maybe we'll do an IVUS now.
Okay.
IVUS, please. Yeah.
run through wire. IVUS 카테터 좀 갖다 줘.
So this is a classic example of the perils of severe calcification.
Yeah. We
The
had a
reason
flow
why
at
you are
the
doing
time,
IVUS
so-
is that what? What's your purpose to do the IVUS?
To determine where exactly the flaps are. So the IVUS can help us to determine the origin of the flap and to see whether a dual lumen catheter may be able to allow us to re-enter into the true lumen. There is a segment on the angiogram where the artery is significantly dissected.
그리고
And if that's the case, we may use a dual lumen and see if we can re-enter.
14.
Dr. Grube, what's your opinion?
Yeah, Dr. Gwon, this is Eberhard Grube.
Yeah,
Very
nice to
nice,
meet you.
very nice to see you. I just wanted to ask a few questions while you were working on it. Is OCT your preferred strategy to determine calcifications and the extent of calcification over IVUS? And
Actually,
if you look at the ostium, did you see ostial involvement of the left main?
Actually, my usual practice is to use IVUS for the left main calcified lesion, but Ali is the expert of OCT, and recently he published a paper that the criteria for atherectomy by OCT. So what was that, Dr. Ali?
Right, so we published that if you have 0.5 millimeter of thickness of calcium, 50% of the arc of the vessel calcium, and 5 millimeters in length, that you really need to use some advanced lesion preparation strategies, such as, for example, atherectomy.
Then
So
as-
what did OCT teach us in this situation? This is a calcific protruding nodule that's at the ostium of the OM. We haven't gone back completely to the ostial left main because on the angiogram it doesn't look particularly diseased. But there's no reason that the OCT is not able to do that. That would simply require a small disengagement of the guide catheter, and we would be able to get this. Where we would have more trouble is if the left main is very, very large, 5.5 or larger. In those situations, it can be difficult. Francisco Brazada published that 1 in 5 frames of the left main may be inadequate for total visualization, but 80% of the artery can be visualized with OCT.
So if you, with that extent of calcifications, and, when you talked in your initial strategy how to prepare the lesion, decalcification, thinking about road ablation, since the extent of calcification not really circular, when you do road ablation, obviously you can't protect the other branches. Would, for example, shockwave be an option? You could wire all 3 and then try to see whether shockwave would do something to the calcium?
So as you know, Eberhard, we just published the Disrupt CAD2 data in Circulation Intervention last week as a simultaneous publication with an OCT sub-study.
But now I prefer to focus on the bailout procedure for the obtuse marginal. What's your suggestion? So I like to have IVUS image for the first wire, first, but not the second wire, first wire. So I think, I'm not sure. Anyway, the first wire, going to the 9 o'clock, going to the 6 o'clock. I'm following get the catheter
Okay,
down.
Dr. Gwon?
Yep.
We are moving to the Seoul National University and we'll come back.
Okay.
Okay?
Thank you.
Okay.
Thank you, Ali.
Thank you.
Dr. Gwon,
Hi. Welcome.
hello.
Coming back.
How are you?
So, yeah, I'm stable now. Anyway, so you get the floor all right. So yeah, we did the star technique next. So I don't know why, but the flow at the time was good, but I cannot show you. And the 5 minutes, 10 minutes, the flow was compromised. Next. So we had discussed about what's the next move.
Yeah.
What's the next move? Still, we are not sure. The wires in false lumen, where to where, we don't know. Next. So we thought it was a true lumen, but the tip injection demonstrated that there might be a false lumen. Actually, we don't know.
Don't know.
We don't know because the proximally is compromised. So flow cannot be reached a bit because of the dissection proximally. Okay, so we are not sure. Next. So we need to be sure the wire is a true lumen. So we changed to the crusadeable.
First we IVUS.
First we did
IVUS on the true lumen wire.
IVUS, please. IVUS 좀 보죠.
So just to summarize what we did before that point is we knew that the wire that's in the continuation circumflex was in the true lumen because we had flow from the beginning. So we IVUSed on that wire and then identified where the false lumen was, and it appeared to be proximal to that segment.
IVUS.
So the IVUS actually was tremendously helpful.
Please.
It also showed to us exactly where the intramural hematoma was. And so we knew that the distal flow was compromised because of a proximal intramural hematoma, which we further dilated and considered cutting balloon.
Previously.
But based on your first OCT image, the dissection starts just before the ostium of the diagonal branch, obtuse marginal branch, right?
Just after.
Just after the OM branch, but we didn't image distally with the OCT catheter. We only imaged the very ostium. Okay, so go ahead.
That's right.
So this is what we did in the meantime, guys. So we used a Crusade catheter, dual lumen catheter on the true lumen wire, and rewired with a workhorse wire into what we thought was the true lumen distal to the dissection. And then we re-IVUSed, which you're going to see now, on the Crusade wire that entered into the distal OM branch. And and that's what ensured for us that we were actually in the true lumen. So start this distally, this IVUS run, please. Can you go to the previous IVUS?
그다음
Previous IVUS, before
전
stenting.
걸로.
Okay, perfect. Okay, so this is the IVUS run on the wire that's in the OM1, and you can see that distally, it's very hard for us to tell. You can see the pericardium proximally. And here, you can see that here we're in the true lumen distally because the calcium is on the luminal surface.
본 게 있었는데.
There's a calcific nodule here. And very quickly after this branch point, you'll start to see that we re-enter into the false lumen.
나봐요.
So we'll tell you when so that's still calcium that's in the true. Okay, so that's the proximal vessel. Okay, next IVUS, please. Next IVUS, please. Thank you. Show us the
아까 그냥 제일 마지막 순간으로 가죠.
and Professor Gwon, let's show them the angio after we
Yeah,
use that
yeah.
strategy.
Actually, I cannot find the angio, but then at some point we are sure that this
This is a stent, right?
yeah, stand previous 아까 끝났던 거.
맨 마지막
Here.
거.
Okay.
다음.
This is the. Yeah. Okay, so this is the IVUS on the what we believed was the true lumen. This is actually after the stent.
Yeah, 더 앞으로.
Go back.
앞으로. 더. 다 보이죠?
Okay. Go back.
더 앞으로.
Ah, good. All right.
Yeah.
So what you can see here is now we are in the true lumen distally with the crusade wire
Crusade, yeah.
that secured our distal vessel.
Yeah. Anyway, the wire in the 6 o'clock, we think this is the true lumen at least. So using this wire, we use the crusade and the wire, the obtuse marginal.
Go back one. We may be able to show it.
And
Back one more. Back one more. Back one more. No.
Back,
Okay, we didn't
back.
save that.
back.
This.
This might be a crusade catheter. Anyway, so back.
This
Yeah,
is it.
this
This
is
is the
it, yeah,
crusade.
yeah,
So we have the crusade. We leave the wire in the circumflex, the distal circumflex, which we knew was in the true. And on the way back, we actually re-enter into the side branch wire. So this is, in our experience, the best strategy to use this technique. Leave the wire distal in the true at 6 o'clock and then re-advance. Next.
Next. So at the time we performed the IVUS, and you showed that, right?
Next. Yeah, I don't think we got that one. But
Yeah.
in any case, we confirmed by IVUS that we were in the true lumen distally, and then we stented. Go forward. Go forward. Go forward. Forward. And then we put in a 2538.
And this angio, you can see that just proximal to the ostium of 6 o'clock wire, that is the ending zone of the false lumen. Maybe it can be extended a little bit more.
Which we
but-
actually marked very carefully with the IVUS, so we knew where we were going to be able to land our stent. Next angio, please. Okay, so this is a very important shot. We changed angles so that we can see the late flow enters into the side branches, and you can see at say
right lower side.
right. So like 4:30 or 5 o'clock, what you see is basically contrast entering the small branch vessels of the rescued artery.
Right.
This was how we knew we were in the true lumen based on angio. Next. And then the IVUS confirmed. Next.
So with the balloon, 2.5. Next. This is fluoro. Yeah,
Okay, so now we're
this is-
secure. Next. And this is the stent.
Yeah.
Can you
this
show
is-
the stent after the IVUS, please?
Yeah, 2.5, 38 millimeter synergy stent.
To start distally. Okay, so this is our stent. So
I
this is a,
not IVUS on the screen, please. IVUS 띄워주세요.
They have, I think, on the bottom.
Oh, yeah, okay.
Okay,
at the
this
bottom.
is a very important. Go right to the distal. Distal.
Yeah,
Distal,
that's
please.
all.
Yeah, I want to show them the trilaminar appearance on the IVUS, so we know we're in the true lumen.
there.
Okay, good. Go ahead and play. So what you'll notice at 11 o'clock is the three-layered appearance of the artery, which confirms we're in the true lumen distally. And then we stented.
A little small. Yeah. 2.5 is small, but we need a post-dilation afterwards.
And you'll notice there's actually some compressive effect from the intramural hematoma compressing the stent. But the key aspect is that we have now secured the distal true lumen. So this is pericardium at 12 o'clock. And now you can see the plaque on the outside. This is true lumen.
It's ostium.
And what you're
Anyway,
gonna see
congratulate.
at the very ostium, this is our problem now. Freeze that. Go back forward 2 frames.
조금만 뒤로 가볼게요.
Still you have a dice.
So this is where we need the help of the audience and the panel. We've made our plan. Go forward a bit. Show the flap. Play.
Angio, 다음
And
뷰.
stop.
Okay, stop.
다음 뷰.
Stop.
Go back 2 frames. Right there.
Okay,
Stop.
stop.
Okay, perfect. Now, what you can see is that our IVUS catheter is in the true lumen. There's a calcific protruding nodule at between 12 and 1 o'clock. And outside of the IVUS is the false lumen. That means we cannot lose this wire
Yeah.
because we may easily enter into the false lumen. Therefore, that precludes our ability to easily rotablate the proximal LED.
Right.
So
It's a little clear in the angiography. LA caudal stent is covered by 3, 4, or 5 millimeter distal to ostium, still compressed by the hematoma. As you can see here in the IVUS. So there is actually wire entered the false lumen about 4 millimeter just after the ostium. So I agree with Dr. Ali that we are not sure. Possibly we can do that, but we are not sure that we enter into the stent after rotablation. So maybe we need to change the strategy to just a kilo stent. First stent from the OM to left main, then to LAD, or we can to be sure about the stent expansion with the still rotablation after removing the wire from the optis marginal. There are 2 options.
So what does the panel think? Who would
So
sort
that,
of pull out the wire?
intimal flap is just after the carina, right?
Right.
Right.
Yes.
Okay, any question and comment from the panel? The length of flap is very short, right?
Very short.
Yes.
Less than 5.
So my opinion is you can do rotablation without wire, then you can penetrate that kind of thin intima very
Yep.
easily.
I want to
We can try
understand
that.
something. The only, Gwen,
Yeah.
hi, it's Eric Finkelstein.
Yeah.
I want to
yeah, nice
understand,
see you.
hi,
Yeah.
the only reason that you're gonna hesitate whether to do a rotablator or not is due to this prediction
expansion.
by OCT, right?
No,
No.
in the angiography, it's definitely there are calcification.
I mean,
Well,
even
I
on the
see,
IVUS,
I
you
see
can it's
definitely
severely calcified.
calcification, not in the trifurcation. I see in angio definitely calcification just after that. So if rotablator would be just a rotablator, I won't hesitate. But since we have some issues here with the rotablator, I'll try first to dilate with the balloon to see how it behaves, and they take a decision. We know we're not afraid anymore to do rotablator after balloon and dissection and so on. We used to be afraid of it long time ago. So I'd rather do a predilatation with a balloon, look the way it behaves, and then take a decision. What do you say?
Using a scoring balloon or just a regular balloon?
I'll try it with just a regular balloon.
For the LAD.
Did you do OCT
Zian?
from LAD to left main?
No,
We haven't yet. We can do that now. We're happy to do that. We can
Okay,
OCT
so,
the LAD.
yeah,
We
yeah.
secure. We have a wire in our circumflex to secure it. I think we can predict it's going to be a calcific protruding nodule,
Yeah.
just like it was in the OM.
So only concern is that I asked Dr. Ali that the OCT forceful injection might be extend the force lumen into the left main. What do you think?
And so in the core lab experience, that's extremely unlikely. The reason is the flap is very, very short, and we don't really need a huge amount of penetration of dye. So I think that's unusual. It's a theoretical risk more than an actual risk.
Yeah.
So I have no hesitation to perform OCT in this LED. So we're going to do that now. We're going to swap over from the IVUS to the LED.
Epicoder.
에피코다.
So one of the questions for the panel, of course, is how much does that osteal flap, which is very thin, concern you? Maybe guide in.
Yeah. 당기지 말고.
Any comment from the panel?
It's hard to say.
Resistance.
Okay, it's not going. No,
It's
it's
not going.
prolapsing.
Right.
So this is not going. So we need to
Yeah.
either, we're going to have to dilate this.
Yeah.
3.0 볼륨.
Still, I didn't decide rotablation or not.
Even we can do a gentle predilation.
OCT first?
We need to dilate before we can get the OCT down. It won't go. It's too tight.
So the OCT,
Rotablation first.
Okay.
Yeah?
Yeah.
Why
So, well, if we're going to rotablate, we have to pull the wire. So what about, can we take a
So-
poll from the audience and from the panel? We'll do what you
run
say.
through wire. Let me try run through wire to the circumflex
Sure.
with the wire and stay. I could try another wire.
Okay.
Test myself.
Sure. I mean, the only concern here would be that if we pull that side branch OM wire and the flap occludes the stent, that we may end up in a mess because the stent is underexpanded and we could easily end up with the new wire outside of the stent.
Okay, I will test myself. We can safely get into the circumflex.
Because
spider view.
I think that the
Spider.
given the
Spider.
size of the hematoma and given the compressive effects we're seeing on the IVUS,
Yeah.
it's not, it would not be difficult for the wire to end up behind the stent. Yeah, I think that's, yeah,
No? Yeah.
that's
false
behind the
lumen.
stent.
Test.
테스트.
Okay. I'm not sure.
Yeah, you see,
You're right.
I think this is not worth the risk.
Yeah.
We've rescued. I think we're going to
Yeah.
go ahead and do a culotte and not
Yeah.
rotablate the LED.
It's outside of stent.
And this is
Definitely.
very, unless, I mean, one other strategy would be to go ahead and dilate the entire circumflex so that this could be minimized. That would be our next strategy. Shall we do that? Shall we dilate the circumflex, post-dilate it a little bit?
Yeah. Try a little bit more. Okay.
Okay.
I'll give up.
Okay.
So maybe, shall we
don't
do
wanna
a
take a
3.0
risk.
NC inside the stent?
Yeah. 3.0 NC balloon.
So we'll do a 3.0
Something
NC, then
NC
we'll
balloon.
retry.
Yeah.
If we end up getting behind the stent again, or behind the flap, then I think we're just going to complete the culotte by angio
Yeah.
so that
without rotablation.
we just got the note here that you have 7 to 8 minutes left. Not that we want to rush you, but so for your planning, okay?
Thank you, Everhard.
Actually, I think I have shown you everything we have. So emergency bailout
You
procedure.
actually did.
So I think this ended up being a nice case
Yeah.
because it shows the reality of
Yeah.
real-life calcific disease.
You like that we are in trouble, right?
Well, I never like to be in trouble. I like to get out of trouble.
And I mean, people, the audience,
Oh,
and
the audience,
panels who
yes.
like it.
It's like the gladiator effect.
Yeah. Glad.
Right, Everhard?
That's right, yeah. But you know, you've done a beautiful, I mean, this is beautiful for us to see and to watch. I mean, you've really done very, very well.
So this is just a great example of the new sort of chip equipment that we have. We used a STAR technique to reestablish flow. We used intravascular imaging to mark exactly where our true lumen was. We used a Crusade dual lumen catheter to rescue our distal vessel.
Right.
And we're using the imaging to help us decide what the next steps should be for our procedure.
So, since we want to take advantage of your imaging skills, is that what you usually do when OCT instead of IVUS, or are you using both?
So my practice is about 50-50, Eberhard.
Yeah.
For severe calcification, I prefer OCT because I feel like it can help us predict
18.
whether or not we need to do
Deflate.
whether we need to do
Under
lesion
expansion.
preparation with atherectomy or with IVL or OAS.
Yeah.
Yeah,
18.
And that's actually
So-
routine in our cath lab.
20.
yeah.
20. This is not
This is
expanded
18.
very
Okay.
well.
Dr. Gwon, this is the Hong.
Yeah.
Okay. Personally, I
Right.
prefer the imaging guided the PCI procedure, but I'd like to raise some issue. The timing for the imaging tool, actually, when you look at the angiogram, is a very severely tight narrowing in the left main bifurcation. When you look at the circ, there is a very severe calcific. Only in the based on angiographic appearance is some tortuous. So it is not real good candidate for the OCT images. You know, the strength is the cast strength is not good for. So what is the main issue of these cases? You would like to show us the very beautiful stand deployment in the left main bifurcation, but the issue is changed. You show us the beautiful the beta procedure, but in the current situation, if you do the lower ablation first, and the left main and the ostium of the circ, and then do the imaging tool, you can more beautifully show us the more better result. So the
Dr. Ali, you can answer
timing
that.
for the imaging is maybe
We
방금 거.
completely agree.
방금 거.
So if your imaging catheter can cross a lesion easily, then it's worthwhile taking an image. But really, lesion preparation is as important for imaging as it is for stent placement. So we agree with you that actually the next step, if we were going to rotablate, should not be imaging. We should rotablate if we do pretend there's not a bailout procedure in the circumflex. We would rotablate first, then image, then help us decide size and dimensions of our
Yeah.
stent.
right. Lower ablation in the
So
LAD
you
and
are
obtuse marginal,
planning to have a
and then do the OCT in both sides. You can frontally do the other procedure.
Yes. And typically, outside of the left main, we wouldn't really.
Inflation.
This is where just dilating the ostium of our LAD here.
Yeah,
You can
18.
see it
18.
actually popped.
18.
If you look on the angio, we got a nice dilation here. This is
Okay.
reassuring. Okay, so we're going to image now. So we've got a good lesion preparation, we think, maybe
So-
suitable for imaging.
Since we have 6 more minutes,
Yeah.
just a word on lesion preparation. Apart from word ablation, a word about orbital and a
So-
word about shockwave. What's your thought on that?
Great question, Eberhard. So
OCT.
we have identified in the osteocircumflex a calcific protruding nodule.
Right.
Likely in the left main is also going to be calcific protruding nodule.
Right.
In my opinion, the optimal lesion preparation strategy in that case is actually orbital atherectomy. The reason is because it precludes you from having to use multiple burrs, and it also is sort of the best to orbit and cut down the amount of plaque or the amount of calcium. Rotablator, because of the wire bias, can very easily slide immediately past of this calcific nodule.
Right.
So as you know, I mentioned earlier that we just published the OCT sub-study and the Disrupt CAD2 study. And one of the limitations currently of current technology is actually still going to be a 90-degree calcific protruding nodule. There's no really good therapy at the moment.
Yeah.
It's not going in.
That's okay,
because,
we can do the,
yeah,
get
yeah,
the ostium
yeah,
here.
just the ostium.
Okay, so let's
So there is some dampening. Okay, pressure is good.
Okay.
Okay.
Sine?
Yeah. Just look. It is not a dissection, right?
There is
Catheter.
another dissection, yeah.
Can be a catheter itself.
Maybe also from dilation, let's
Yeah,
see.
yeah, catheter. Okay.
Okay, so let's see
That's
what we
doable.
have here. Yeah, so actually you'll see something here, guys. There's a calcific fracture up here at 12 o'clock. So we've actually fractured the calcium, if you guys can see the OCT. There's another fracture here at 12 o'clock.
It looks ugly.
Looks ugly.
Yeah.
Yeah. Okay, so I think that's going to preclude us, or I'm not sure that we really need to do a rotablation in
Rotablation?
this case. We've
Okay.
already fractured the calcium.
That's right.
Okay, I'll go with the balloon.
So we're going to go a little bit more
3.0.
distally.
자, 발로
2.5, 3.0,
3.0.
3.0. And the balloon stand from the mid LAD to
Yes.
the left main. So any predilate that, and I stand first to the obtuse marginal to left main,
3.0 발로.
right? So secure the dissection proximal
Yeah.
circumflex.
We also now have a
Yeah.
we also have a dissection in the LAD.
Really?
Yeah.
So let me
So we
check.
have the same
Angio,
problem
angio.
twice.
At the mid LAD, is that what you're talking about?
Sure.
Yeah,
Yeah.
there's a dissection in the mid LAD from the probably from the balloon dilation
You're doing
Yeah,
a good
there is
job there.
some, yeah.
of lesion preparation.
Actually, this
try to get out of
demonstrates
trouble,
that
but
Everything you can.
risky part of the OCT. Actually.
Yeah.
Gwon, Ali, I want to say something regarding the technique that you're going to choose.
Yeah.
I mean, it looks like obvious to take a culotte to the left main, to the LAD and the circ. But I think that in a case like this, where we saw heavily calcified ostium of both of them,
Yeah.
I'd rather consider again and think that T-stenting or mini culotte is safer, because the only bad news
Yeah,
with culotte
inflation.
is that you are leaving one of the big branches unsecured while you are
Yeah.
putting the
Yes.
stent in. And in cases with this calcified
Deflate.
bifurcation,
I'm
I
sorry.
sometimes prefer to do the T-stenting or mini culotte in order to secure both of them.
Thank you.
14.
I think that's a very, very valid, good point,
Yeah.
especially since we now have a dissection in the LAD.
14. So I think deflation. I'm sorry, Dr. Ali, but next time I prefer IVUS. So there is there was the virus on the false lumen. That's the first event, but maybe OCT can enlarge the first lumen. So yeah, that's what I feel. So okay, more secure.
Okay,
case,
Dr. Kwon, because of time limitations, thank you for showing us a great bailout case, and then we will let you finish finish polishing up the left main bifurcation.
Right.
Thank
yeah,
you for your
Tulip is
contribution,
boring.
and
Thank you.
congratulations
Yeah,
on your
thank you.
results.
Stenting.